Hi, folks. I'm Noelle Cockett, president of Utah State University, and very pleased to welcome you to our Blue Plate Research program, where we share USU research and outreach on health and well-being. We hope this series helps contribute to a healthier, happier Utah. We're grateful for the new connections we've been able to make over the last year through our virtual events. Today's presentation is ideal for our broader audience, as we will feature an important statewide program that focuses on the opioid epidemic. While many of us may think this happens to someone else, in fact, last year, non-fatal opioid overdoses in Utah rose by nearly 20% from the year 2019. In part, we know that this rise is due to the inability to hold therapy and other treatments in person due to COVID-19. Today, you'll hear about how USU is addressing this challenge by coordinating resources for substance use disorders and training for opioid addiction recovery programs. This program, referred to as the HEART Initiative, stands for Health Extension, Advocacy, Research, and Teaching. The HEART researchers and educators are helping and working to improve health and well-being in the state, specifically in response to the opioid epidemic. The HEART Initiative shows the power and importance of USU's extension programs. As a former vice president of USU Extension, I'm very passionate about the mission and reach of Extension and the outcomes they deliver to communities and to individuals. USU is Utah's land-grant institution, and it has a century-long presence across every county in the state. That provides us the connections and know-how to administer programs in communities ranging from Logan up in the north, Uinta Basin over to the east, down to Blanding and Washington County in the lower part of the state. Extension's core purpose is to connect research results and evidence-based programs with the people that need them. Many who are familiar with Extension associate it with agriculture and gardening, but its reach is much more expansive and much more broad. Extension specialists and our county faculty provide statewide services in the areas of business, finance, relationships, nutrition, natural resources, and much more. We're pleased to share how these research and outreach programs make a difference in Utah. Dr. Maren Voss, a health and wellness faculty member with the HEART Initiative, will be our main presenter today. Before we start, I'd like to express special appreciation to Regions Blue Cross Blue Shield of Utah for their strong partnership and support of our series. A special thanks to Jim Swayze, president of Regions Blue Cross Blue Shield of Utah. We're sorry he had a conflict and won't be here with us today. Amy Kahn is the Region Blue Cross Blue Shield of Utah and serves as the executive medical director there. And Audrey Gladsby is the strategic communications manager for Regions Blue Cross Blue Shield of Utah, and again provides great support to us as we present and structure our programs. We're happy to have Miguel Rivera, Director of Business and Community Relations for Regions, here with us today, and he will make a few brief remarks. Miguel?
Good morning, everyone, and thank you, President Cockett, because as you said, opioid abuse continues to tragically impact many of our communities. And Regis would also like to thank Utah State University and Dr. Voss for highlighting this important topic and research that we're conveying through Blue Plate Research. As a health insurer, we're troubled and concerned by the fact that more lives are being lost to the overdose during the pandemic, we have been working very closely with healthcare providers to reduce opioid prescriptions while making sure that our members are getting effective pain management. And through these collaborations, we've decreased opioid prescriptions for our members by 51% since 2015, but the work continues. I'm really looking forward to learning more about the Heart Initiative from Dr. Voss today, and the difference that its evidence-based programs are making throughout Utah. We share the goal to improve health and well-being in Utah, and that is why we support the important research and we sponsor Blue Plate Research. I encourage everyone today to take advantage of this opportunity to engage in a discussion with Dr. Voss about a topic that unfortunately affects us all and our communities. And thank you for joining us today, and we appreciate your time. Turning the time over to you, Lisa.
Thank you, Miguel. I'm now pleased to turn the time over to Dr. Maren Wright Voss, who will share her work in developing and administering programs to address substance abuse disorder in Utah. After her presentation, Maren will be happy to take your questions and respond to some key issues and thoughts you've shared in your RSVP responses. While you're here, I hope you'll take advantage of her extensive expertise. Anytime during the presentation, feel free to type your question in the chat and we'll put it in the queue after the talk. Now, feel free to turn your video off while we share the presentation.
Wonderful. Thank you so much for the introduction, for Miguel, that awareness of what's already been being done in the state, and also Dr. Crockett for that great introduction into how extension can make a difference. So I am, as they said, Dr. Maren Wright Voss, and I'm a health and wellness faculty member with USU Extension. And this Blue Plate Research special is about opioids. And there is just a lot to talk about with opioids. So if I were a neuroscientist, I could talk about the long-term opioid use, how it transforms the nervous system, how it fundamentally changes how people perceive pain. And if I were a human development researcher, on the other hand, I might talk about how opioid misuse damages family relationships, how the emotional development children could be harmed when a parent overuses opioids. And then if I were a historian, maybe I would talk about the first evidence of people collecting opium pods 5,000 years ago. A historian might explore how Indo-European trade routes and the opium wars in the 1800s led to opium dens in the early 1900s. And then more recently, there's been the development of synthetic opioids and how those events have led us to the opiate crisis of the 21st century. But I'm here to focus my remarks on opioids from the perspective of a health science researcher. So others study DNA and genetics, but I look at culture and policy and economics to understand disorders that can be co-created by societal and individual mechanisms. Now, I am very practical. In Extension, we're all about programs that make a difference. So I seek to understand interventions that work to combat negative societal factors, and then how can we empower people to help themselves? So that's what we're all about. Today, I'm going to discuss two of my main programs. So there's pain management education and peer support specialists that I want to talk about. This is all part of a harm reduction approach. And I'm also going to talk about how we've adapted our efforts to serve rural Utah. I'm going to talk a little bit more about the Heart team, the Heart Initiative, and my role on it. And then just a little bit of a perspective on grant writing. I have a unique perspective, you might even call it a personality flaw in that regard, that I'll talk about. But before I get to any of that, I want to go over just a bit of history. Let's spend a little bit of time talking about the factors that lead people to opioid misuse and how this illness affects people's quality of life and really why it's a societal problem. So this isn't our first opioid crisis. Before the current crisis, we saw an opioid crisis in the early 20th century. So at that time, opium was smoked in opium dens. Inside homes and hospitals, it was used as like this miracle drug to treat all kinds of problems. And when we look at the historical literature, we see the same kind of addiction issues we're seeing today. Back then, policymakers started to recognize the harms And that's when opioids became a classified drug that you could only get through prescription. And so eventually, with that change, the opioid crisis petered out enough that it was really kind of only impacting the fringe of society. But then in the 1990s, we heard this new outcry from the public. So people wanted better pain management, and patient advocacy groups started talking about this right to pain relief. There was a 1995 address to the Pain Management Society that urged the adoption of pain as the fifth vital sign. And that really caught on. They were saying that doctors needed to monitor a patient's pain and make patients more comfortable. At that same time, and just a little bit before that, in 1980, there was this 5-sentence commentary that appeared in the New England Journal of Medicine, which suggested that prescription opioids really didn't have a high potential for addiction. Astonishingly, that sort of false notion, it was based on evidence, but it wasn't really, the whole story. It got perpetuated over 600 times in the ensuing years, justifying more opioid treatments for pain. So then at that point, pharmaceutical companies responded. They manufactured drugs to keep patients comfortable based on this perceived need, and then they marketed those drugs, justifying them as safe. That's how this current opioid crisis emerged. That chain of events led to a prescription, an increase in prescription by doctors. Perhaps they were a little too easy on prescribing. You then saw that increase leading to an increase in opioid overdose deaths, which you see here to some extent in this first wave. You see it a little bit more here through the second wave, but then I want you to pay attention to the second orange line, because as we started to become aware of this problem with prescription opioids and the addiction issues, doctors started leveling off their prescriptions, much like we just heard about. And then that led to an increase in heroin use, as patients who were dependent couldn't get the medication from doctors. And then more recently, an alarming spike of synthetic opioids with fentanyl on the streets that's led to even more overdose deaths. So back in 2005, Utah had the highest opioid overdose rate in the nation. And since then, you saw how we leveled off. And that to some extent is because our prevention efforts were working, which is a really good thing. But just as was mentioned a minute ago, the COVID impact has really created some additional burdens, and we're seeing those opioid overdose rates spike back up. Here, the American Medical Association in their issue brief offered just this month, they're citing this problem. And so we need to talk again about making sure that we're doing everything we can to address this around our state. So the US Department of Health and Human Services designated the opioid crisis a public health emergency back in 2017. And then in 2018, this HEART team, this HEART initiative was formed, created by USU Extension, and really by a very forward-thinking dean who realized that Extension is ideally situated to bring evidence-based practices into our communities through the land-grant university mission. It just pairs up really well with the partnerships we already have out in the communities. So that's how HEART was started. As Dr. Crockett mentioned, it stands for Health Extension, Advocacy, Research, and Teaching. Everybody needs a catchy acronym, right? So that's ours. HEART is the expanded arm of Extension that's focused on health and wellness. And so 5 new faculty members were hired. They were given this mission to address Utah's opioid epidemic, and opioid harm reduction was our focus from the beginning. I serve Salt Lake County and Tooele County, but many of our efforts are statewide. And while HEART started with 5 faculty, USU Extension faculty from other areas of the state already working on health promotion joined the initiative. So here's a quick video of my colleague, Susie Prevedel. She's talking about her work in Roosevelt and Uintah counties here in Utah, and I want to share that with you.
Making relationships is key to what we do in small towns. It's really nice to be able to reach out to people and help each other get their jobs done. If I can help somebody else in their agency get their work done better, I know they will do the same for me. Hi, I'm Susie Prevedel. I work for USU Extension. I'm the director of the Tribal and Rural Opioid Initiative Resource Center, also known as TROY. I've lived here for about 30 years, and I live just on the Uintah County line. The school that my children attended at that time was Todd Elementary, and it's about 85% Native American students. So from the very first time I started making connections in the community, they were with Indigenous community members, and I've enjoyed working and being part of that community. One of the things we can do working through Extension and using the research that's available to us is if we come in and we're humble and we do a good job listening and we're respectful and figure out really what's not what we need, but what our communities need, then we have a much better chance of helping them get another step up. The science doesn't change, the statistics are there, the best practices are there, the things are there. The way that we deliver needs to change with that. So we really worked with the presentation to leave open space for people to bring in their own specific resource information. We also changed it to reflect the community that the presentations will be giving to. We also spend time with the training manual so that a community member from the community can look at it, work with our experts, and then deliver the trainings to their own community. It's not something that we hold proprietary. In giving our naloxone presentations at the tribal community, who were hosted by Michelle Chapus, we noticed that through multiple trainings, people became more comfortable. They were really willing to give feedback, so it came more of an exchange of ideas on how to make things work better. So we felt that was pretty successful, and we'll continue working that way with our tribal communities.
That importance of listening and those community connections. So it really is about tailoring our approaches to the community. Like Susie, the HEART team, we consider the community members the experts, and we listen to the community and adapt our programs to their needs. One of the first things I heard when I did a listening tour was that our communities needed more pain management options. So they could use something other than opioids, something with less risk to overcome their pain. So that's where I started as a new faculty member, was with pain management. So first off, as we talk about pain management, there is something you need to know. Americans are a little bit unique in our attitude toward pain. Specifically, we don't want to feel any of it. We want it all gone. We use more opioids than per person than any other developed country out there. The second thing that you might be helpful for you to know is that pain is a complicated process. So giving people more opioids doesn't necessarily result in lower pain levels. There's these intricate reaction patterns called the neuromodulation of pain that can result in sort of an oversensitivity of the nervous system where you're feeling more pain than you should based on your condition. All of this is pretty complicated. And one of the things we do in Extension is we create community-facing fact sheets with really easy to understand information using the evidence base and presenting it in a way that community members are able to access it. And so using images like the one you see here, we create a number of community fact sheets trying to get good information out there about how people can find better options for things like managing pain. Another aspect of our success is our partnerships. We've been able to develop some amazing partnerships in Utah. We connected with people at Intermountain Health, with the University of Utah, with Utah's Department of Health's Living Well programs. And we were able to offer these Stanford-based, evidence-based education programs called Living Well with Chronic Pain. This is an amazing workshop series. It takes about 6 weeks. It has about 15 hours of education on pain management using this entire toolkit of approaches, walking people through some of these different approaches and how to use them. And the classes have information on things like regulating sleep, how to make action plans that help you manage your pain, how to pace activity so that you're in less pain even though you're staying active, some gentle movements that can ease muscle tension, just a whole bunch of things, a bunch of cognitive strategies on how to think differently and to use your mind to distract and to experience less of the pain, even if your body's still experiencing it. And we've had just some amazing feedback from people who take these classes. The comments we get are that the classes are transformative and that people are able to stay more active and even be able to use less pain medication after taking these classes. So they've been really effective. But while these programs are awesome, they require a ton of training. And it's been hard to get them into rural Utah, where our numbers are small and we have fewer people to facilitate and to take those trainings to offer the classes. So I'm going to touch on a little bit more about our rural outreach in a minute. But again, Extension is all about making our programs accessible. So we took this same evidence-based toolkit approach, and we created a program that we call PEACE. Again, another catchy acronym, but this one is Pain Education and Community Empathy course. And we created a manual with 12 really easy modules. They're like 12 scripts where people can, walks people through one pain management strategy in a script format. So you can have one facilitator who basically reads through the script, gives people the evidence-based information as they gather. Then they can try out some of the techniques. So they try out things like some simple exercises to get muscles moving again, some ways to reduce tension, some ways to visualize and use your mind to distract from the pains. They practice breathing techniques in some of these scripts. And so people have this little encounter with some pain management strategies, but then they're there together as a support group. And really having a community to support you, to learn about their resources and what they're doing to manage pain has been really, really helpful. These classes have been working so well. We've even started a partnership in Tooele where we've been able to bring these PEACE support groups into the jails, because some of the people we serve come from really vulnerable populations like our prison population. So let's shift gears just for a quick minute, because I want to talk about serving these vulnerable populations. So this is a type of harm reduction. This graph right here shows that recently incarcerated people generally have a higher risk of overdose death. So within that first year of incarceration, it's about 10 times the average. But that middle column, that shows the 2 weeks after incarceration. And your risk of overdose is 40 times the national rate. That's scary. And what that means is I want people packing naloxone as they leave incarceration. Naloxone is this amazingly safe medication. If you haven't heard about it, why it works so well is it can bump the opioid off the receptor. And so what happens is a person can go from having so much in their opioid in their system that they can't breathe to breathing easy again after a naloxone dose just within moments. Now, unfortunately, the most affordable form of naloxone comes in a vial accompanied by a syringe. The good news is it's only about 20 bucks a dose, but as it turns out, our police partners don't really love us handing hypodermic needles to people as they walk out of prison. So, unfortunately, the police-approved version, the nasal spray version of naloxone, is about $100 a dose, and nobody has a budget for that. But with the community engaged work we do, I was able to partner with a nonprofit called Harbor Path, and we received 1,200 of these Evzio naloxone kits. These are an injector style. It's a little bit like an EpiPen. Now, these injectors normally cost about $500 a kit, but they sent it to us for just the cost of shipping. So for us, it was $2 a kit. These are safe. And now in partnership with the Tooele County Jail, people are handed this safe naloxone option as they leave incarceration. And that is the kind of community engaged work that will really have an impact on saving lives in our community. But I call this next little section of what I'm going to talk to you about grant writing to the rescue, because that partnership I mentioned with the Evzio kits was brought to you through the power of a grant. A $2 kit doesn't cost much in terms of grant dollars, but I needed the grant relationships more than the grant money in order to get that relationship to happen. I couldn't have done it without my federal funding partners helping me make those connections. Now, if you spend any time around a university, there's a good chance you've heard people complain about grant writing. I'm not one of those researchers. This could be my motto. I love writing grants. I seriously love writing grants. It's really a sickness, most likely. I see grant writing as this fun, collaborative process where you see a need and you get to creatively think about what's going to fix that need. As I do this, I get to partner with amazing people. Now, the number one partner you're looking for are the people who want to give you the money. And that might be kind of obvious. But you have to ask a few questions. What's their vision? What are their goals? what are they willing to give, and why are they willing to give? So after I find a funder who has a shared vision, then I have to come to them with a really well-developed project and a plan. And I can't do that on my own either. So nothing happens, as you know, in community engaged work with just one person. So this step requires a lot of partnering. I get to work with assembling this team of other community members and professionals, and we get to talk about how we're going to fix this problem. So we kind of like raise this cloud of ideas, things like our hopes and our goals and barriers and budgets, and we kind of let them rain down until we organize this proposal. And what we're doing is we're telling the story of our community need and why we're the best ones to address it, to get things to be resolved. So in that process, there's a lot of emails, there's a lot of paperwork. It typically takes about 2 months. We're turning our dreams into this written proposal that makes sense on paper, that's going to convince the funder to give us money. And then after the grant is submitted, you just wait. So far, with the support of USU Extension's administration, as well as some really awesome people at the Office of Sponsored Projects, we've been successful on every one of our federal funded opioid applications. And because of that funding, I have 2 harm reduction programs running in Tooele County. And then I also have a statewide $2.5 million grant that is really starting to show some big impacts that is pretty neat. It's focused on building the treatment workforce with a really cool new type of professional called a peer support specialist. So again, we're listening to our community and doing what makes sense for our communities. And when we did that initial listening tour, we listened to people in recovery. And one of my good friends at Young People in Recovery told me how much it meant to him to give back to others who were struggling with substance use, and to do something to change those negative societal factors that really make it so hard to advance through recovery. He started a chapter of Young People in Recovery to be that difference because he believed in the power of having a friend. And really, this idea of peer support is one of the most exciting things in the past decade in substance use treatment. You've probably heard of AA. They've had sponsors for forever. But finally, someone started to realize that that idea of a sponsor worked so well, people should get paid to do it. People in peer support, they don't need a college degree because they have a degree in life experience. One of our friends at USARA, which is one of Utah's biggest peer support networks, Mercedes told me, my mess is now my message. So in saying that, she's saying she's using her recovery story as a story of hope and healing to encourage others on the journey. And it's really powerful what happens when you have someone with experience helping you through the way. She's a trained and certified peer, and we need more of those. Why? Because when peers are on the treatment team, people stay longer in treatment. We call that treatment retention, and that means better outcomes. People report more hope, more empowerment, better quality of life, but it also helps the bottom line. We see lower rates of hospitalization and lower rates of future arrest. So societally, it's making a difference as well when we have more peers on our treatment workforce. So you might, if you're new to this idea, wonder what peers do and why we're so motivated to train more peers in the state to help this problem. They can lead groups, they can provide one-on-one support, they do crisis response, they do this integrated health, connecting people to all the types of health support they need. They connect people to resources. So that could be things like housing, job training, help them with interview skills. And they do some general patient advocacy as well as 101 other things. But as an added benefit, being a certified peer support specialist provides meaningful work for the person themselves while they're also in recovery. Recovery isn't just like this 2-month and it's over kind of process. It's an ongoing process. And so to work in that recovery space helps the individual who's in recovery being the peer along with the people they're serving. So it's really a win-win in a war on drugs that really needs a victory right now. Now, I want you to know that Utah has been at the front line in training and promoting reimbursement for certified peers. So here in Utah, they can bill Medicaid if they provide supervised services. And we need peers on our treatment teams because Utah has a workforce shortage in behavioral health. Looking at this graph, Everything in gray is a workforce shortage. We do not have enough behavioral health workers across the state. Then the dark gray is where there's a higher need, geographic needs, and the red is where it's higher need because of low income, where both of those areas need additional services. So getting more trained peers out into the field can help pick up the slack because doctors and counselors can't do it all. I've been talking with some of our partners recently, and it's so hard for them to get trained professionals out into their communities, and peers can help fill some of that treatment workforce shortage space. So we want these certification problems available across the state, but particularly in rural Utah, because rural Utah has been hit a little bit harder by the opioid epidemic. I think you maybe have seen how the Price and Carbon County areas have been extra hard hit. And there's several reasons for this. They have less access to treatment. They have fewer alternative pain management options like massage therapists, physical therapists, some of the other professionals you might need for alternative pain management. They have fewer specialists in their area, and they have people working in more physically demanding jobs. So that means more likely to get injured. And you also see people a little bit more likely to keep working even while they're in pain. So that means needing a little bit more pain relief out in rural America. I want you to check out this graph with Tooele County. That's one of the areas I serve, and it has one of the highest opioid overdose death rates in the state. But check out this next graph. Here's that same data again. Tooele's on the very bottom of the graph here, and you see the high overdose rate next to the treatment resource availability, and you can see how limited the resources are in Tooele, and you'll see that in several of the other rural counties as well. And so we really need to support the workforce out in our rural areas in order to be able to get people the resources they need. So my grant goal is to build those treatment resources. So to become a CPSS, a certified peer support specialist, takes about 5 days with 8-hour sessions. That's about 40 hours of training to become a certified peer, and they pass an exam in order to do that. It's really hard to expect someone who's living on a minimum wage job out and maybe in Panguitch to travel up to Salt Lake City, take 5 days off from work, pay for the hotel, pay for all the other travel expenses in order to get this training to once again go and work in a behavioral health job that also has a lower pay scale than some of the other types of work out there. So one of my grants wanted to make CPSS training more accessible. So we set up this hybrid format where individuals interested in this recovery support training could do half of the work online, and then they could come to just a 2-day in-person training in order to certify themselves with those additional skills that they need to be a peer support specialist. We managed to get a grant that's going to pay for 365 peers to get this training in Utah over a 4-year period. It also gives some stipends to support them because the salary wages are fairly low for people who are certified peers. That will give them some stipends as they do internships and apprenticeships and as they develop their skill set in this area. And we've trained 52 peers in the first year. That again is the type of community engaged work that's saving lives and that can make a difference. So here in USU Extension, we are adapting how we deliver information and services, and it's making a difference, but we can't do it alone. So what can you do to help? Well, if you're thinking that a person with opioid use disorder are just addicts who just need to figure out how to quit, stop. Change your thinking. It isn't helpful to think about the disorder that way. These are people in real pain. They were given meds to help. Perhaps a doctor's prescription made them feel a bit too safe in taking the medication. Maybe long-term use changed their nervous system and it may take years to recover. But there are prescribed medication treatments that can help people if we assure them it's okay to take medicine for addiction. We like to think of it, because addiction is a long-term chronic condition, we like to think of it like diabetes, where we're giving people the equivalent of insulin to help them through that crisis. So we need to change the way people are thinking about access to support and resources to get them through recovery in order to make this difference. So what that means is if you're an elected official, you could maybe hold a town hall, You could encourage harm reduction trainings that give this extra information to county or state employees or to others in your area. And you can support the building of prevention coalitions in your area as well. If you're justice, education, healthcare, workforce individuals, you are one of the people that can connect people to the needed resources. Again, that stigma reduction, being aware of all the types of harm reduction options available is important. And you can conduct those types of trainings at your agency to make sure all of your staff is aware and has that perspective as they help people with the opioid problem. If you're a business owner, maybe you want to sponsor some recovery organizations, some recovery events, or just make sure your environment at work supports mental health. And then if you're a community member, we can each reduce stigma by changing our language, not using the language of the addict, using person first language, those other kinds of things that will support people who are struggling. You can show support for any recovery path, whether it has abstinence or not, realizing the chronicness of the condition of substance use disorders. You can attend prevention coalitions where there's going to be tons of ideas on how to take action there. But generally, I also just encourage you to know the options and the resources so that if you have a friend or a family member in need, you're going to know how to connect them to support, get them the help that they need. So if you want any of these harm reduction education opportunities in your community, we can help through USU Extension. I've been talking about our program implementation, but we do research alongside to make sure that these programs are effective and having the desired impacts. We have naloxone trainings, we have those pain education trainings, stigma reduction trainings, and all of these resources, community classrooms, pain education, in order to help in our communities, because prevention is important. We know that there's a measurable benefit from the pain management techniques we've been sharing that can help people manage pain with less risk of opioid overuse. And we know that peer support is this amazing new approach to treatment. And if we can get more peers in our communities, that's also going to make a difference. So remember, we can adapt our messages and services, and let's meet people where they are and make a lasting difference. And thank you for your time and your interest in this topic. It's so important.
Thank you, Maren. I hope the presentation has helped to provide some assurance to you on the options available to those in our state combating substance use disorder. I hope that you've been able to learn about some of the new tools and resources that can be brought into your own community. I invite you all now to turn your cameras on for the Q&A session. Again, you can submit your question in the chat. For the Q&A session, I'd like to turn things over to Wyatt Archer, who will be our moderator. Wyatt?
Awesome. Thank you, Lisa, and thank you, Maren. It's been really fun working with you on this project and learning how helpful what you do is. So we are both here at USU's Kaysville Education Center, which houses Extension and the statewide campus offices. We received a lot of questions in advance through our RSVP form, and Maren's gotten a chance to look at those and even structure her presentation around them. But we'll be including some of those RSVP questions, but we also want to focus on questions submitted here and in the live chat. So please keep submitting your questions. Don't submit them to me personally. I have a lovely team of people going through and just like feeding me the questions that should be asked next. So please, if you're submitting questions, don't send them to me in private message. Okay. But let's just get started with an RSVP question from Amy Kahn from Regions Blue Cross Blue Shield. She would just like to know more about strategies that help clinicians facilitate members into timely treatment.
Yeah, so this is an interesting idea. So in Extension, we are mostly on the education and community support side. And so we don't get engaged with the clinical side of the treatment services as much. But one of the really exciting models out there that I've heard about recently is called the hub and spoke model. And one of the things we have done is to make sure clinicians are able to get medication assisted treatment waiver training, because if we can bring treatment into our primary care offices, then that's going to help people get timely treatment, because we're going to catch people before they get too far down the road of dependence. We can get them medication assisted treatment when the doctor first notices the signs of a little bit of opioid misuse or overuse. And so if doctors in primary care are comfortable treating their patients with some really safe medications, buprenorphine is one of them, then we can get people timely care because they're getting it sooner. The doctors in primary care are noticing the problems, giving people the treatment. And it really is like diabetes and insulin treatments. It's this chronic illness that we need to catch, be aware of, catch it early. And then if we can get primary care treatments on board, then that's going to be timely treatment. And it's really hard to address timely treatment when a person's so far down the road that they've started to turn to street drugs as their solution, where there's been criminal justice involvement, where they're now waiting lists for the inpatient treatments for addiction recovery. So if we can do that timely treatment early in the process, that's going to make a huge difference.
Awesome. And now we have a question from Angeline Clayson. She's from USU, and she said she would like to know more about any community support programs, financial support for those interested in substance abuse programs, and how employers can best support employees and their dependents in this area.
In Tooele, with one of our grants, we were, there really is this sort of gap between people's medical insurance and their individual resources and getting all their needs met, like helping them with a short-term housing crisis or things like that. And so out in Tooele, we were able to get some grant funding that we call recovery support community funding. And so there are small grants that you can get that can address some of those individual needs, but that's a bigger problem. And so really just getting the whole community involved, reducing stigma so that there's resources and support across the community in a really comprehensive way might be one of the only solutions I can suggest in that regard. And employers can be part of that by making sure they have the mental health resources and sort of just a mental health friendly environment at their work as well.
Yeah. So we aren't getting any questions submitted in the chat yet. Maybe I scared y'all off. If you want to send them to Shalise McDonald, if you kind of want to be anonymous, you can send them to her. And then, but I guess now we'll move on to a question from Margaret Hostetter. She'd like to know more about resources for the homeless receiving,
Yeah, so it's a really good question because I'm sure, as you're aware, mental health disorders, substance use disorders really are overlay a lot of some of the other societal problems we have that lead to homelessness and some of the other really difficult situations. And that's not an area that we address a lot in Extension, but we do work with all our community partners trying to make sure people have awareness of the different resources, but that's a larger societal issue. And hopefully reducing stigma and getting people treatment earlier can help a little bit, but I am not the expert in that area. And it's a bigger problem that we really need to come together and address. I agree completely.
Yeah. Hopefully that helps, Margaret Hostetter from Utah's Behavioral Health Planning and Advisory Council. So now Amber Braun from Overdose Awareness Utah, she would like to know more about aftercare following treatment.
So again, the USU Extension, we're really focused on the education side of things and not the clinical side. And so we don't get directly involved with the once individuals are in treatment. But aftercare is such an important aspect of getting people the support they need.
Sorry.
So aftercare would generally be after a person has a diagnosed substance use disorder and has received some initial treatment to try to address the condition. But part of what you need to realize in this is that, again, substance use disorders are chronic conditions. And so when a person leaves that initial phase of treatment, whether it's inpatient or a residential treatment center, the problem hasn't gone away, and they're going to need ongoing support. And so that definitely is part of what our community awareness, stigma reduction, it's okay to take medication while you're in treatment. All of that messaging is going to help. Like there's some people who think that if a person takes medicine for substance use disorder, they're just placing one drug for another, replacing one for the other. And we need to get away from that mentality. Again, we don't say that when a person's taking insulin for their diabetes. And so just supporting people through every aspect of recovery might make steps toward getting people the aftercare they need. and getting them support they need in their communities, but that really is a larger issue.
Greg Bell from Utah Hospital Association would like to know, how are USU's programs integrated with local mental health agencies?
Yeah, so since we aren't on the clinical side of things, we connect with the local mental health authorities and agencies, often in grant writing partnerships. We sometimes offer some of our education classes directly in their centers. I know that's happening up at Bear River Mental Health, where we're able to bring the naloxone trainings and pain education and nutrition education and other sorts of programmings into their treatment centers, because we focus on education and getting that information out there. So you'll see some of those partnerships, but because we're engaged in the communities, just about in every community in Utah, Extension is working with those local mental health authorities to make sure that we're connecting on resources and that the education we're doing is supporting those agencies. I think that's our main point of collaboration. And maybe there'll be more in the future as the health and wellness arm of Extension expands.
Okay. So Miguel Rivera from Regions Blue Cross Blue Shield of Utah would like to know, in your research, does data suggest that the opioid substance abuse problem disproportionately impacts underserved or minority communities?
So health disparities are something we see in general disproportionately impacting, like health in general is more challenged in those underserved communities. And absolutely that is true in mental health and substance use disorder areas, as well as general chronic conditions and other areas. We've been doing a lot. You heard Susie talking about the outreach they do to their underserved communities out in her area. But a lot of the like rural areas are also considered underserved populations. And so some of our outreach has been specifically to rural citizens, and yeah, that's absolutely an area that we serve. So we basically have to do needs assessments in each community and figure out who are the people that need the services the most. And those are the kind of grants we apply for to try to get services where they're needed.
Yeah. I went and I met Susie, and that's like, I'm the one who made that video, and just seeing her talk to all these people from all these different organizations who knew her, because she's just like connecting them to the resources and trying to just get like, oh, you need this, I can get this person over here to provide you that. Like, it's pretty impressive, the kind of work happening out there. Oh, and Susie is here. Hi, Susie. So Robin Hatch from Northeastern Counseling Center would like to know, is it helpful if we are able to, it is most helpful if we are able to access the data discussed down to a local level. Why is that sometimes difficult?
Oh my gosh, I would love to get more local data because then we know better who needs the help and how to address it. And it's been really hard. It's been my entire time as a faculty member. I'm trying to get data from the state that reflects more the small area and local areas. It's been really hard. I haven't gotten much. And part of the problem is that as the numbers get too small, it can potentially be identifying for individuals, and they need to protect the data at the state level. The state's been amazing. They have an opioid dashboard. You can get county level data from there. But I totally agree. It'd be nice to have data down to a more local, minute area, and we'll keep working on it.
Okay. So
that data really helps us with our grant writing, and I love grant writing. So yeah, the more data we can get, the better.
So Allison Heffernan from the Utah Health Policy Project would like to know more about the opioid epidemic and incarceration rates.
Yeah, so one of the things you see is that people who have substance use disorders start to have more criminal justice involvement. So there's absolutely an impact on incarceration rates. But one of the areas we're most concerned about is, in that graph I showed you earlier, is that because individuals in incarceration have been away from the substances that they tend to misuse for a period of time, their level of tolerance and dependence drops. And so if they go back out on the streets after and as they're released, use the same level that used to be safe for them, it's now no longer a safe level, and their body's too responsive, and it can create an overdose. So that's one of the main areas we focused as we try to support people who are criminal justice involved. But peer support programs are also awesome for supporting people who have criminal justice involvement. A lot of our peers have had criminal justice interactions, have felonies on their record. They understand the system. So that's one way to give more support to people. But absolutely, there's an overlap between substance use disorders and criminal justice involvement. And we need to do a little bit more to try to address it.
Yeah. Kara Swenson would like to know, has HEART needed to pivot their work/outreach during the pandemic?
Yeah, so we definitely shifted to a lot of virtual trainings, but to some extent with the community engaged work we do, we were still, producing the community fact sheets. We were, some of the treatment centers had closed down, some of the internships for our certified peers disappeared for a period of time. But in many ways, we were able to reach more people through virtual education. So it hasn't necessarily been a bad thing. We also did a little extra grant writing during that time. And so there's been a little bit more opportunity there to serve. So overall, COVID has not harmed our efforts, but we did adapt and change a little bit.
Yeah. You mentioned briefly the other pillars of the HEART initiative and focused on what your work is in it. Can you spend a little more time talking about some of your colleagues' projects and what they're working on?
Yeah, so we have prevention as one of our pillars, and so much of our work falls under prevention. There's also stigma reduction, and so a lot of my colleagues are engaged even more in stigma reduction than I am. For me, it's more of a secondary outcome of some of the work that we do. As we get more peers into the communities, as we do more pain education, stigma reduction happens around that. Others are doing community dinners and really direct outreach to communities to bring up conversations. There was a project that was done called the Opioid Narratives that we collected people's stories of recovery and the opioid crisis in Utah, and digitally archived those and have those and told those stories in some community conversation dinners so that people, so that it wasn't just somebody off in Salt Lake in a back corner, but it was people in your community that you saw and you understood, that creates some of that better awareness that can create change. So some have worked on projects like that as well.
Yeah. So HEART is currently focused on the opioid. I'm trying to read this one. HEART is currently focused on the opioid epidemic, but it is about all types of community health. Exactly. How are you hoping to grow your focus in the future?
Yeah, so one of the areas I like to serve is our aging population. So I've been able to do that with pain education because older adults have a little bit more pain. So our pain education programs have been really helpful. And they also have higher risk of opioid overdose as there gets to be more medications and medication confusion. So it's been a good tie-in, but I really like working with the older population. And so cognitive strategies for reducing memory loss and Alzheimer's risks and falls risks are one of the areas I really enjoy. Some of our others have worked on like body image projects to reduce some of the fears and concerns there, especially as young people have more anxiety and depression. There have been a lot of mental health projects. We do suicide prevention, mental health first aid kind of trainings. So our group is very involved in that area. And there have been several who are very involved in physical health. I mentioned the Living with Chronic Pain series that we work with, but there's also one called Living with Chronic Conditions and Living with Diabetes that several HEART faculty members are trained in and provide to their communities. So lots of different areas around health.
Yeah. Best case scenario, draw us a picture of what an optimal system for opioid harm reduction would look like in Utah. What type of resources would we put into it? What type of connections and partnerships would we need? And what type of results do you think could we see? That's a lot of questions, but
that's a lot, and it would be comprehensive and big. So some of the steps in getting doctors be more aware of their prescription practices have obviously been helpful, but it was some recent evidence came out that if doctors, there's this controlled substance database where you have to check before you give an opioid prescription if the person has been getting them from other doctors. Anyway, so that's one of the tools that they use. And there was some information that came out recently from the Journal of American Medical Association that did a sort of an analysis of use of those systems, and they call them prescription drug monitoring programs. This is way too much detailed information. But what they found is that if doctors just sort of cut people off if they don't do this sort of comprehensive care model when people are starting to misuse opioids, then checking one of those databases actually resulted in more deaths and more negative outcomes down the road. So you really need a comprehensive where the doctor is addressing the need, ideally that hub and spoke model that I mentioned, where if the primary care doctor sees the need early, addresses it in their clinic, where we don't have to refer someone out where they may or may not show up at that specialist office, but we can treat them here in clinic. That's going to be a part of the comprehensive model that we need, where it really is viewed like diabetes, where it's just a primary care concern that we deal with in our office. More of those safe medications, buprenorphine, that can support people when their bodies have become sort of a little too used to the opioids, and they have those long-term neurological changes that just make life really hard if you don't get support. So that's going to be helpful. Community support will be helpful. And you're always going to have people who end up on that addiction spectrum with some of those criminal justice problems, with homelessness. And so anything we can do around harm reduction to support people as they get into those areas until they can make a choice for recovery would be helpful as well.
Cool. Thank you so much, Maren. That's the end of our Q&A. But before I turn things back over to Lisa, I just want to acknowledge the high scores on our opioid research quiz that was at the beginning of this event. Kira Swenson, Ashley McCollum, and Teresa Thur. You can expect to see some USU swag in your mailbox in a week or two. Thank you, Maren, and I'm going to turn it back to Lisa.
Thank you, Maren, and thank you, Wyatt, for a great discussion. And thank you to all of you who have joined us today. And thank you for your continued support of the research at Utah State University. If you're interested in hearing more about Dr. Voss's research or other USU stories, we've recently posted an episode of Dr. Voss's work on USU's research podcast called Instead, that you'll find the link to Instead in the chat. Thank you again to Miguel Rivera and his team at Regents for their support of this series. Before you leave, we'd appreciate you sharing feedback with us on the event. We have a quick one-question poll, plus a slightly longer survey, which is linked in the chat window. Finally, after more than 1 year of doing Blue Plate research in an online format, we're hoping that our next event will be in person. That event is scheduled for January 2022 to be held face-to-face at Gallivan Hall in downtown Salt Lake City. We're excited about our slate of speakers for the upcoming year. One speaker will include a discussion of the causes and challenges of online adolescent bullying, and that will be presented by Diana Meter, an expert in children and teen relationships. She is scheduled to present in January 2022. We then have scheduled Sarah Freeman, an assistant professor of biology here at USU, whose research in neurobiology seeks to find novel treatments for individuals with autism spectrum disorders, social anxiety disorder, or schizophrenia. Her presentation is scheduled for June 7th. And finally, a presentation on the science of impulse decision-making by Greg Madden is scheduled for September 16th. Dr. Madden is the recipient of USU's top career research award, and he has studied for years decision-making impacts on children's nutrition choices, addiction habits, and other situations. We hope to see you in person or at one of our exciting events next year. Thank you again and enjoy the remainder of your week.